I would say, to be honest, I don't feel very comfortable to be an imager between so many interventional cardiologists and cardiac surgeons. I will try to give some data regarding the pre-operative CT assessment before TAVI. Some technical aspects. When we talk about CT acquisition for TAVI, we have two steps actually. The first step is the gated acquisition at the level of aortic annulus, and the second step is for the access, the non-gated helical acquisition of the arterial system. Both of them, of course, require contrast agent. This is the outline of my presentation. Some aspects regarding the role of CT in the diagnostic workup have already been mentioned by the previous speaker. I would like to emphasize the role of calcium score in cases of aortic stenosis that were not solved for the severity. And these are the cases, as already mentioned, with low flow, low gradient with normal ejection fraction, or with reduced ejection fraction but without stroke flow, stroke volume reserve in stress echo. We have two thresholds, more than 2,000 in men and more than 1,200 in women. Most of the times it's regarded as severe aortic stenosis, and this helps us to continue on with these difficult cases. At this moment, I would like to say that we have to pay attention in our measurements, even if it seems so simple in a calcium score to measure it. We have to pay attention in motion artifacts, the so-called banana artifacts, because each calcification could be measured twice. In case there are pacemaker leads, we have to pay attention not to include LVOT calcification or mitral annulus calcification. Sometimes in the mitral annular aortomitral junction, it's difficult to recognize which belongs to the aortic valve and which belongs to the mitral annulus, and of course we should not include aortic wall calcifications. Going on to the main part of my talk regarding the pre-TAVI planning. The most important, of course, measurement in pre-TAVI planning is the annulus measurements, which is a plane at the base of 3 Hitch points. We put 3 Hitch points at the base of the aortic cusps, and we can measure the aortic annulus using different tools, freehand tool, polygon, or spline. We are cared for both area and perimeter, and minimal and maximal diameter of the aortic annulus. Area mostly for Edwards, perimeter mostly for evolute R, in order to decide which size fits best for our patient. These are some errors that we can perhaps undergo when we measure aortic annulus. We should include the calcifications in the annulus measurements. After we measure the annulus, then we have the annulus dependent aortic measurements, which are of course the left and right coronary heights, which we are interested that they are more than 10 millimeters in order to be safe and exclude any coronary obstruction. The sinotubular junction height, in this case we measure also the height of the sinuses, we are interested that there are more than 20 in order to be safe for our TAVI implantation. Sinovalsalva diameter, sinotubular diameter, and ascending aorta diameter. It's very important that we mention in our report the degree of LVOT calcification in case there is one, because it's very important for the interventional cardiologist to know that there is excess of LVOT calcification, which can lead to potential complications, including PVL or even aortic rupture. We describe it with semi-quantitative measurements, including mild, moderate, or severe. Another measurement that we mentioned in our report is the fluoroscopic ankle. Actually, we delineate with the commissure of the left on the non-coronary cusp in order to bring at the same level the 3 coronary cusps and guide the interventional cardiologist which is the best fluoroscopic angulation. At this moment, I would like to say that there are, of course, advances in pre-TAVI measurements. This is a study design where they use the data acquired from the CT. They upload them to specific software which is called Mimics in order to make three-dimensional models of the whole aortic annulus and ascending aorta. And then they use other software which is called Phelps Heart Guide. They try to simulate the TAVI implantation in order to measure the risk for PVL before, of course, PVL or either pacemaker implantation before, of course, the operation. Other important measurements, which I will not go further, are for the access. As mentioned before, we perform also a non-helical, helical, and non-gated whole arterial system CT in order to measure our arterial system from the femoral axis up to the aorta. Going beyond to some more specific data regarding the RCT, since 2021 there is a new classification of bicuspid aortic valve according to CT data. So we say either there is that our bicuspid valve is tricommissural, or which is the functional bicuspid, as we said before, or bicommissural with rough type, or bicommissural non-rough type. Bicommissural rough type is a Sievers 1, and bicommissural non-rough type is old Sievers 0. You know better than me the procedural implications in case of BAV. We may have dilated or horizontal aorta, long raphe, low coronaries, dense leaflet calcium at the coronary ostium and near the commissure, and of course, which is very important, a calcified raphe or also a calcified LVOT. In case we have a bicuspid aortic valve without raphe, but with two commissures but without raphe, then the definition of the three-dimensional structure, we don't have 3 hinge points, we have actually 2 hinge points, so we have to be very careful in our measurements of our annulus plane. In bicommissural rough type or in tricommissural BAV, we have actually 3 hinge points, so we may proceed with our annulus measurements like in tricuspid aortic valve. It's suggested not only to calculate the virtual basal ring in bicuspid aortic valve, but also the virtual raphe ring, and also it's suggested that we have to measure the length of the raphe, and it's more than 50% of the diameter, or the volume of the calcium is more than 300 square meters, then we have to expect perhaps a transcatheter under expansion. Now some data regarding the valve-in-valve, what we have to pay attention to. There is of course a higher risk with valve-in-valve for coronary obstruction. The most important risk factors is the virtual to coronary distance less than 4 millimeters, and it will have a very narrow sinotubular junction. Virtual to sinotubular junction distance less than 2.5. There are some papers that they give some guidance regarding what we have to pay attention to when we have a valve-in-valve. So if our previous prosthetic valve extends below the coronary ostiums, then we don't have any problem, we proceed with the valve-in-valve. If the leaflets, or the posts actually, and we suppose the leaflets, extend above the coronary ostium and the sinotubular junction, then, and the sinotubular junction is very narrow, then it's the highest risk for coronary obstruction. And then we have to consider either other procedures more complicated, either basilica, for which we can give guidance, or even for chimney procedure. In case there is a mitral prosthesis, metallic prosthesis, we have to measure the distance of the annulus from the mitral valve. In case it's less than 4 millimeters, then there is a high risk for interactions. And closing to the end of my talk, the TAVI, the CT is very important also for recognition of post-TAVI complications, and one of these is subclinical leaflet thrombosis, which is called HALT, hypertension leaflet thickening. In order to see how often it is, we have to do studies. So we have to make routine to do CTs after TAVI, which is not a routine still. There are some studies which we try to perform in First Department of Cardiology in Athens in order to see how often is the halt 3 months after TAVI and if there is a correlation with peri-procedural complications. This is an example of an acute thrombosis and a CT post-TAVI where we see the hip attenuated masses in the aortic valve. And this is a case from my personal archive recent with the post-TAVI CT in a case where a chimney procedure was performed, where we can see the stent extending from the left main towards the ascending aorta between the struts and the wall of the ascending aorta. In conclusion, dear colleagues, cardiac CT guidance is critical in TAVI planning. Good knowledge of anatomy allows accurate pre-procedural planning, especially in complex cases. Thank you very much for your attention.
Thank you, Dr. Benetos. Excellent presentation. Are there any questions from the panelists or any comment?
No, thank you, George. Great talk. A lot of things you mentioned. I'm wondering about you show us multiple ways of measuring the annulus. You said, I think, 3 or 4 methods of measuring the annulus, and I'm wondering if this is the reason, because sometimes it has happened to me to receive reports from different sites, from the same patient, and get different numbers. So I don't know if the way of measuring the annulus leads to different measurements. And the other point is that you show us computer models simulating the valve, and I don't know if you can simulate the valve-in-valve, a TAV in a biprosthetic valve before the implantation, so in order to check and make sure that you won't obstruct the coronaries after the implantation.
Thank you for the questions. Great questions both. Regarding the first question, if there are differences in measurements between 2 readers, then most of the times it has to do that they define different plane, and not because the one uses polygon or the other uses freehand contour. So if you have exactly the same plane in both readers, then either the polygon is suggested to use, but whatever method you use, it's going to give similar results. Regarding the second question, perhaps I forgot to mention it, but in order to examine exactly what's the danger, what's the risk of coronary obstruction, you have to do a virtual implantation of the valve. That makes the software, so either with the shape of Evolut or Edwards, or either a ring is virtually implanted inside your annulus, and then you can measure the virtual coronary valve to coronary distance. So the virtual distance, the distance that will come if you implant this specific size of valve in this specific annulus.
Okay, Dr. Zanis.
Yes, congratulations for the presentation. I would like also to ask, when we have compelling data from the echocardiography about the severity of the aortic stenosis, is CT pre-procedural planning accurate to guide what we're going to do if the aortic stenosis is severe? I mean, the CT calcium score or other parameters for the CT scan. Are these parameters accurate for decision making to do the procedure or not? I mean, if the aortic stenosis is severe or not.
I wouldn't depend on the CT. If we are sure from the echo that the aortic stenosis is severe, then I wouldn't deny an operation to a patient according to CT measurements. Sometimes we do a planimeter CT and it doesn't seem so severe, the stenosis, but the echo report says it is severe. That most of the times has to do that in CT you measure anatomical structures, but in echocardiography you perform also functional functional studies. So it's different.
Sorry, but I mean also the opposite. If the echocardiography is not sure if the aortic stenosis is severe, I mean, say in patients with, let's say, paradoxically low flow, low gradient AS or other compelling echocardiographic studies, then can we base our decision on the CT scan? If the calcium score is very high, if the movement of the...
in extreme cases, for example, a calcium score more than 3,000, then I'm sure that's severe stenosis. In other, I have cases that the calcium score is 100, so I'm sure that it's not a severe stenosis.
I would like to ask how accurate is the measurement of the calcium in outflow tract in order to avoid some ruptures?
In calcium score scanning, it's sometimes difficult to distinguish between outflow tract calcium and aortic valve calcium. So sometimes you cannot exactly, because these are in continuum actually, these masses are connected, so it's difficult to delineate where it stops the aortic valve and starts the outflow tract.
Any questions? Dr. Pilatis?
Thank you for the very the question I have is in cases with bicuspid aortic valve. In cases with bicuspid aortic valve, which measurements do you give for valve sizing from annulus or for intercommissural distance, or the Casper method or Lyra method? Which one do you use? And which one do you use do you give to the interventional cardiology in order to decide which valve and what size valve to use?
In clinical practice, if I have a bicuspid but tricommissural, I give a virtual basal ring as in tricuspid. If I have a bicuspid with RAF, the same, but also I give some more information regarding the LVOT calcification or the RAF calcification. Most of the times in bicuspid, these bicuspid valves with RAF, there is extended LVOT calcification, which I also measure, which I also mention. The problem is in cases of severe zero, so bicuspid, bicommissural without a RAF. Then I give the virtual to basal ring, and if it's asked, then I also give the measurement at the RAF level.
Thank you very much.
Thank you, Dr. Benetos. Next speaker would be Dr.